Okay, so we're going to move on to our last talk now, and that's by Liz Wilson, who's the new lead ICC nurse for GeoCity and King's Health Partners. Liz started working at GeoCity in, I think, about 2020, based at King's, and has now moved to the lead role. And she has a special interest in psychological support in ICC and has worked closely with the IMPARTS team at King's to integrate mental wellbeing questionnaires into the clinics. As well as building CNS-led follow-up clinics to help support signposting. And Liz is going to be talking to us today about that, embedding the mental health screening into ICC clinics. So thanks very much, Liz, and please start when you're ready.
Thank you for the intro, and thanks very much for having me today as well. I'm hoping a presentation at some point.
There's this movement on the screen. Yep, I think, yes, that's in presentation mode, is it? Yep, I think we're all good to go.
Good to
Thank
go?
you.
Wonderful. Yeah. Thanks ever so much. So yes, hi everybody. My name is Liz. I am one of the clinical nurse specialists working at Guy's and St Thomas's and King's College Hospital. And I'm going to be talking or giving you a brief overview in regards to embedding mental health screening into inherited cardiac conditions clinics. I'm being ambitious by attempting to show you a video, because this video introduces the link between mental and physical health way better than I ever could. Please do shout if it's not playing all right, but hopefully it will all be good.
The mind and body are inseparable, and mental and physical health conditions are often connected. The average life expectancy for someone with a severe mental illness such as schizophrenia or a learning disability is 15 to 20 years shorter than for someone without. And many people with physical health conditions such as diabetes, arthritis, or heart problems also suffer from a mental illness, such as depression or anxiety. In fact, did you know that 30% of people with long-term physical health conditions also have a mental illness? Or that nearly half of all people with diagnosed mental illness also have at least one long-term physical condition? And that when mental and physical health problems are combined, people are less able to manage their conditions properly, and their health outcomes become worse. By simply asking someone how they are feeling physically and emotionally, we can improve the care they receive. But we shouldn't stop there. Local health services still separate care into physical and mental, and often fail to share patient information. People are often passed between different parts of the NHS without the right connections being made. And on many occasions, healthcare professionals are not aware that their patient has multiple health conditions. Evidence shows that by removing the barriers between physical and mental health care, we can help people to manage their different conditions, improve their health outcomes, and even prevent unnecessary health problems for some people by identifying risk early. For example, by training staff to screen patients for common mental and physical health conditions in all care settings, the right support or treatment can be identified as soon as possible. By raising awareness of the connections between mental and physical health, and by working together in multidisciplinary teams across primary, secondary, and community care, we can make sure that our NHS services are delivered in a way that best meets the needs of our patients and service users, allowing them to live longer and healthier lives. Mind and body, don't separate the inseparable.
Hope that played okay. I didn't hear anything to the contrary. So that video was just an introduction, really, on a more broader spectrum in terms of the importance of mental health and embedding psychological support for patients across the board, regardless of their long-term condition. More specifically for inherited cardiac conditions, we're very, it's an open door when it comes to the fact that these are conditions that are very complex, and patients that have or are affected by ICCs have very complex needs psychosocially along with their families. It's really important for us to understand that their perceptions and their understanding of their condition is actually very closely associated with their level of psychological distress and also their compliance in terms of therapies as well. It's really important for us to look at the risk and decision making, especially with young people, when it comes to things such as devices, which will obviously have a huge impact on them long term. And these quotes really are just to show the fact that there has been some, but not a comprehensive review as to the level and the complexity of the psychosocial needs of the patients. The most recent one being, and it was mentioned earlier, Tuti's work in regards to psychoeducational intervention, and a lovely quote from her thesis here about how patients value the relationships they have with their clinicians, and this plays a massive role in their adjustment and coping with their conditions as well. So there was obviously, when I first started this job, which wasn't that long ago, it became apparent to me very quickly with interacting with patients and speaking with their loved ones that there was multiple levels of needs from a psychological perspective. There was the broader living with a chronic condition and the risks associated with that, but also a lot of grief and trauma because of the loss of young loved ones, particularly those that are young. There's guilt associated with the fact that a lot of our conditions, there's obviously that risk that it gets passed on from a parent to their child. There's lifestyle changes, in particular for those conditions that affect those that are in competitive or high intensity sports or that enjoy them. And this can mean a complete change of lifestyle for them. And that's only touching the surface of all of the aspects of care outside of the physical sphere that we have to touch upon when we're looking after patients with ICCs. Now, this has been recognised. This has been recognised for many years now. I'm sure there are plenty of other guidelines and frameworks that highlight the need for psychological provision. In ICC in particular, the 2005 National Service Framework for Coronary Heart Disease in Chapter 8, which is talking about arrhythmias and sudden cardiac death. The 2013-14 service spec for inherited cardiac conditions through NHS England, and the hot off the press ESC guidelines for the management of cardiomyopathies all touch upon and all agree, as I think all of us do across the board, that having embedded psychological resources, and in particular embedded clinical psychologists, are good for all, in particular for ICC. The problem is we're skint, and that's probably not going to change anytime soon. So we have to think outside of the box, and we have to use the tools that we have and the resources we have available to us in order to try and improve the mental health support for our patients. So when we sat down and thought about this as a team across KHP, we thought about our aims and what we wanted to achieve. We wanted more effectively to manage long-term conditions and improve health outcomes, and we know that that is aided by good mental health support, but within the scope of our current service and our current levels of skills as well. Of course, we have to have the sell, and the sell is that if we reduce the amount of mental health and psychological needs of patients and support them appropriately, then there would be a reduction in our DNA rates, and therefore our appointments and our service would be more efficiently utilised. Strengthen evidence through data collection. in order for us to continue to thrive, to get that embedded clinical psychologist within the team, but also to improve in the interim the resources and the services that we can provide for patients within the ICC multidisciplinary team. So this is where IMPARTS came in, and we're incredibly fortunate that we had the IMPARTS team to talk to about our ambitions. So IMPARTS stands for Integrated Mental and Physical Healthcare in Research, Training and Services. And basically this is a team that works within King's Health Partners purely to bridge the physical and mental health psychological services for patients. What they could offer us was an embedded electronic mental well-being questionnaire, and basically this questionnaire is formulated with key assessments, for example the GAD-7, which is an anxiety score, the PHQ-8 for depression, as well as the cardiac anxiety questionnaire, which is actually it's a heart-focused anxiety questionnaire that was developed back in 1999, mostly for emergency departments to help distinguish between heart-related anxiety and obviously physical symptoms as well. So patients are offered 24 hours before their appointment a link in order for them to access those questionnaires. There's also some addiction material on there as well, and that enables them, if they wish, to be able to complete screening in time for their appointment, and that's reviewed with them by their consultant within their main ICC appointment in clinic. So we spent some time back in 2022. We were incredibly fortunate that we had some clinical health psychology students who were undertaking interviews and also reviewing our IMPARTS data with some very interesting results. We were very fortunate to have students again this year, but that data is still being reviewed. So this is a little bit out of date, but I think still relevant. And in summary, basically nearly 20% of our patients were scoring moderate to severely on both anxiety and depression, which I think is in keeping with the figures you saw earlier in the video, because we haven't accounted for mild anxiety and depression here as well. And as you can see, that's quite a considerable amount of our population out of those questionnaires that came back. Out of the cardiac anxiety questionnaire, the main flag for us, and it's split up into 3 sections in regards to responses, either to cardiac related symptoms or fear of, and that was that a lot of patients avoid predominantly activity for fear that it will cause them issues, and of course increase their risk in terms of sudden death as well. We, back in 22, unfortunately only got a couple of interviews out of patients, but within those interviews they were incredibly useful to us, and the main themes out of that very much focused upon the fact that there is a huge delay, and it's a necessary delay because of the system that we work within, between starting to come to our clinics and either the screening process for first-degree relatives or a diagnosis for those affected actually being made. And of course the importance of social support as well as education on conditions as well. So really interesting results. Part of them we were expecting in terms of the levels of anxiety and depression, but also just as a scoping exercise as well in regards to how we could potentially help and support patients. So it's a score-based system because that makes everything a lot easier in terms of how we actioned those questionnaires, because it was really important to us that this wasn't just about data gathering. We needed to be able to follow through and be able to safely support patients as well. It's a busy slide and I won't go through it, but basically this is just an outline of the process that we use, and the main new feature that we put in order to support patients through this pathway was the nurse specialist follow-up clinics that was specifically designed in order for us to signpost to support networks heavily reliant upon for example, charities, and we're incredibly fortunate that we do have a number of excellent charities that do support us. There is, of course, other services such as IAPT, and he had to be very, very aware of the fact that, you know, as nurse specialists, there is a certain level of skill when it comes to us being able to communicate with patients in terms of their needs and have a holistic approach. But of course, we're not trained psychologists, so we had to be very mindful of keeping within our scope of practice. A lot of us don't have access to clinical psychology just for the sake of funding, as I said before. So this was all about helping patients understand their condition and signposting as well. And the results of that in terms of patient feedback has been predominantly very, very positive. And these follow-up clinics can happen on any medium, telephone, virtual, or face-to-face as well. Another aspect of our sort of aims in terms of what we wanted to be able to produce through that IMPARTS data was resources, and these were resources that were specific to our ICC population as well. So not just looking at anxiety or depression, but actually looking at psychological support and that kind of mind-body link very specifically. And this is just an example, and this isn't available yet. This is still going through a patient information process, but just an example of a leaflet that one of our MSc students designed in relation to Brugada syndrome, psychological support for Brugada syndrome. So of course, all of this was within the resourcing that we had within the ICC service, but we have to be very mindful of the fact that a lot of hospitals don't have ICC services, let alone resources within that. This is something that obviously needed time, and as I said before, we know that we're all skint and there's not much budgeting for that. So in terms of our future, and I think it's really important, certainly from my perspective and my interest in terms of the psychological support of patients, to have a future aim and to be quite realistic about the fact that funding is not going to be something that we're going to come by easily. I think exploring avenues such as AI and how we can use that to look after our patients. For example, we have patient educational videos through an app called MedTap. So how we can utilise AI for that, as well as utilising all the amazing networks and alliances that we have available to us, and breaking down those boundaries, as the video said at the beginning. And of course, if we can get some funding predominantly through charitable grants, of course, we'll do that as well. So that is a very whistle-stop tour of the work that we've been doing with the IMPARTS team. And I'd just like to very much thank them for all of their work. Unfortunately, the IMPARTS project is coming to an end now, but please do go on the Mind and Body Improvement Network. It's a KHP initiative. It's still the same teams that work within IMPARTS, but they've got some amazing materials on there for patient resources, patient leaflets, as well as training and education as well. Thanks very much.
Thanks very much, Liz. Really important work again. I feel very lucky to be part of a service that does have a psychology team embedded in it. So anything you can do, I'm sure, has been very, very helpful to the patients until we get any more money. That is hopefully next year, right?